anytime. I will be your correspondent about this education. Yeah, at the end of, I don't want to give too very detailed information, but let me just briefly say, if you want to be a dentist or dental therapist in the UK with this program, yes, you will have to do this. You will have to be the permission to work, and you will find your job, and you will be eligible to work in the UK. And I would like to thank to our sponsor, Sharamco, for helping us to organize this education. Honestly, I'm not a dentist, although you can see a doctor that is totally irrelevant to being a dentist. That's why I have no idea what will be taught now. My profession is business, but the presenter, our lecturer, Professor Dr. Esra Üzerçelik, is one of the main specialists, very few one, in restorative and cosmetic dentistry, based in Izmir, a dream city in Turkey. And she will be presenting this, mastering the techniques of direct composite veneer. And at the end, we will have a Q&A session. So you can just keep your questions right down to chat, but I will recommend you to wait for the question and answer session at the end of this session, to write down to the chat there on Zoom, and she will be answering all of your questions. She'll do her best. Yeah, I don't want to take your time for long, so I will write down to the chat area my email address and our info email address. And if you have any question about those educations and training, please contact me. So I will be leaving the microphone, and don't worry, I will close my camera as well. You won't see me anymore the last minute to see me. And yes, I'm leaving it to Professor Esra. It's your turn.
Thank you so much. Yes, it's my time. And good afternoon, everybody, because it's afternoon in Izmir now. Today, I'm going to make a presentation on composite restorations. But before the presentation, also, I would like to thank to Nice Bridge Academy and also Sharamco for their kind invitation and also kind support. Today, our topic is direct composite veneer, mastering the technique. And also, it's the first part of our training program. I'm going to give theoretical knowledge about the technique, about the process. But this theoretical knowledge will be on the practical methods and practical steps. First, I would like to introduce also myself. I live in Izmir, and Izmir is a metropolitan city in western part of Turkey. Yes, we have very really beautiful city. It's the third famous city. It's a very modern, developed, and busy commercial center set around a huge bay and also surrounded by mountains. I stay at a university in Izmir. It's a state university, and I'm working as a full-time professor. Also, I'm the chief of the Department of Restorative Dentistry, and I'm in charge of undergraduate and postgraduate dental education. I give lots of theoretical and practical courses in that programs. Yes, I'm a clinician. My field is especially aesthetic dentistry. Also, I'm a researcher at the university, and I have nearly 100 journals in peer-reviewed national and international articles in national and international journals. Today, our topic is direct composite veneer, and the composite veneer is the restoration on labial and proximal surfaces, but they're very thin restorations. And their indications are discolorations, the rehabilitation of discolorations, shape and size abnormalities, malpositions, caries and defects on labial surfaces, and hypoplasia. What are the classical indications? In my clinical practice, I generally use this technique for the rehabilitation for the treatment of pec laterals. In that cases, especially laterals are very small, and the patients with that problem generally refer to our clinics in younger ages. I think direct composite veneer is a very good option in that cases. And also we get very good results in that cases with also direct composite veneers. In young patients for the aesthetic rehabilitation or anterior teeth, my first indication is direct composite veneers. Generally, these patients refer to our clinic after orthodontic treatment for diastema closure. Also, we get good results with the patients. Old restorations, sometimes there are large composite restorations on the surfaces, and sometimes the other problems are accompanied with these restorations like size and shape and also discolorations. Also, in that case, first we can prefer direct composite veneers. The other problems are discolorations. Sometimes we encounter really severe discolorations on anterior teeth. In the past, we prefer indirect restorations, but today we have really good composite restoration materials like opacers, and we can mask really severe discolorations with direct composite materials. So also I use this technique in discolored teeth. Sometimes in some circumstances, yes, the best choice is indirect restoration in that patient, but unfortunately he or she cannot afford its cost. And also, in that case, I prefer direct composite veneers because of the economical reasons in that patients. Yes, of course. Also, there are some limitations of direct composite veneers, like gingival irritation, marginal discoloration, surface discoloration, surface roughness, and wear. But I think the most important one is the fractures. Why? Because we can solve the other problems with minimal invasive interventions, also with repair techniques. But unfortunately, when we encounter with fractures, especially when they're located on incisal 1/3, in that case, you have to probably replace the composite veneers. It's the main contraindication and main problem in the clinic that we encounter with such kind of restorations. Is there any contraindication? Yes, the main problem, the main contraindication is about, I think, occlusion problems, especially when the central incisors, maxillary central incisors, occlude with mandibular central incisors or lateral incisors. In centric occlusion, in that cases, I do not prefer composite veneers. Why? Because composite material is more fragile in thin sections, and in this situation, we can see many fractures in the clinic. So I used to prefer indirect restorations in that occlusal problems. For a successful restoration, to make a successful restoration, first we have to make a detailed treatment plan, including detailed patient assessment and also selection of proper equipment and also proper technique. This is very important. When a patient comes to your clinic, first you have to take records, and also you have to assess gingival head, gingival symmetry, caries risk profile of this patient, occlusion, and you have to evaluate this patient according to the SMILE design criteria. Then the photos are really important, especially for two reasons. First, you have to remind the patient his or her initiative, because probably he or she will forget his initial view of teeth. So it's really, I think, critical point in the treatment. And also, you can use these photos in the treatment plan in future states. So please take plenty of photos before the restorations, before, I think, all restorations. And which photos? From point of aesthetic treatment, you have to take a smiling photo to assess soft tissue levels, and lips at rest will give information about the incisal edge position. 12 o'clock will also give information about incisal edge positions. You have to evaluate the incisal edge position. It's really important in especially smiling. And retracted view will also find you some information about the aesthetic plane of occlusion, and retracted close photo will even give information about the function. You can just take these photos from the patient at the beginning, and after that, you can start your treatment. And gingival health is really important, and you have to assess the gingival in terms of symmetry and health. And before the treatment, if there's a problem in gingival health like bleeding or plaque accumulation, you have to solve these problems. You have to improve the gingival health or hygiene of the patient. And gingival symmetry is really important, especially when the patient has a high smile line. You have to first deal with this asymmetric gingival level, and you have to advise this patient to periodontal surgery before the treatment. It's really, I think, good important point in terms of the aesthetic appearance. It does not just depend on tingles or gingiva, it's really important. And high caries risk is a critical point in the long-term evaluation and long-term performance of your veneers. But because just making is not important, also the maintenance is very important. The patient should use these restorations for at least, I think, 5 years in a clinic. And the failure risk for high caries patient is unfortunately higher. And in this patient, you have to pay attention to some factors for better marginal adaptation, for preventing secondary caries, and also for preventing marginal discoloration. So you have to etch the enamel. If you especially use self-etch adhesives, because the bonding performance of self-etch adhesives is lower to enamel compared to HMEs adhesives. This is very important to prevent marginal discoloration and adaptation problems, and also secondary caries in high caries risk patients, because they're high caries risk patients, and the risk for caries occurrence is high in that patients. Use composite brush for better adaptation. Also, this will prevent the forming of any gap between the restoration and root surface. Polish the surface well. You have to get very glossy surface to prevent the plaque accumulation in that patients. And I advise use smoother secondary and tertiary anatomy in that patient, because they can produce retention areas, and in that places, unfortunately, especially high caries risk, there can be plaque accumulation in fertile periods. So smoother anatomy will be better. And occlusion also should be carefully evaluated.
Should take up all of the forces. Notice.
During occlusion evaluation, you have to check overjet or bites, contact points, and also incisal guidance, lateral movements. The thickness of composite resin should not be less than 1.5 millimeter, where there's a tooth-to-tooth composite contact. This is very important. You have to check this in, especially during evaluating the contact areas and lateral movements, especially if there are diastemas between lateral incisors and canines. And if you're gonna build composite with canines, in this situation, you have to check lateral movements before the restoration, if there's enough place for this build-up for the composite resin. Next step is smile design. This is really popular subject nowadays, and people are asking to us smile design. You can make a smile design for us like this. There are lots of questions like this. Yes, first I think we have to learn the patient's aesthetic desire, because yes, beautiful, yeah, the word beautiful, it means different things to different people, and it's crucial to establish the patient's preference at early stage, I mean before the restoration. So in our clinic, we ask our patients, do you like the visual nature, straight, wide and perfect, or wide and natural, or just clean, healthy and natural? Straight resembles the symmetry, and wide resembles, in the case, the shape. If our patient wants straight, wide and perfected, then generally we advise them indirect ceramic restorations. But if they prefer wide and natural or clean, healthy and natural, in that case, direct composite is also very aesthetic and good options for that patients. In smile design, you may use digital or manual techniques. It's not important, but also digital techniques facilitate our procedures, and there are lots of softwares for this in the dental market. For digital smile design, you need photos, and you have to upload these photos to software, and software gives you some advisors for this digital smile design. But if you don't use, also you can use manual technique, and in the manual technique, you also need photos and diagnostic tests. And by this way, you can make a plan using smile design criteria. The smile design process are assigned into 3 parts: face analysis, dental facial analysis, also dental analysis. Yes, and also there are lots of criteria in each group. But today we're going to talk about especially midline, lip anatomy, nasolabial angle, tooth exposure at rest, smile line, incisal edge lower lip position, number of teeth visible during full smile, and also gingival margin position, axial inclination, tooth shape, and proportion. Midline is very, very important, and the location of facial midline should be parallel to the maxillary dental midline. 2 to 4 million shifts to right and left, yes, it's acceptable, but we don't want any angle between the facial midline and also dental midline, and we encounter this problem especially in crowding cases. We have to correct this angle, especially with preparation. And also lip anatomy, this is also important. You can assess how prominent or retreated the lips are from also frontal view and also profile view. Generally, thick lips require longer teeth, and thin lips require shorter teeth, and the degree of lip support from profiles helps the dentist to determine if the case should be built up or facially or not. And tooth exposure at rest, yes, this is also important criteria. To assess amount of tooth display at rest, we ask our patients to relax their lips and say the word Emma, then freeze. This shows the existing incisal edge position. In young patients, generally 3 mm of maxillary central incisors is visible, and this gives our patient a yacht appearance. So, lengthening the incisive edge of our patient's teeth will result in a more youthful appearance. We have to also consider the tooth exposure at rest because of this property. And big smile is really important in the smile design because big smiles gives us information about smile line of the patient, soft tissue levels, incisors, fluids, number of teeth visible during full smile. The smile line is important and it gives information about the amount of gingival display. Unfortunately, high smile line cases will be more challenging in the anterior composite restorations. How many teeth show in a smile also should be assessed because, yes, if more than 6 teeth are visible, we have to consider shape and size of the posterior teeth when we designing the new anterior teeth shape and shape. This is important. Every human is unique and special and reflects the smiler's personality. We have to evaluate the incisal fluids, incline, shape, and dominance of teeth together. Also, it gives some information about the character of the personality of the patient. For example, rectangular dentate shapes, strong dominance of the central incisors and canines under lateral incisors, as well as plain incisal edge, and rectilinear 3D dental positioning on the arch in the occlusal view gives a strong personality also patient.
Sorry to interrupt. Can we just a little bit raise the voice, please?
Triangular or trapezoidal dentate shapes, standard dominance, inclined incisal edge, angled 3D dental positioning on the arch.
Dr. Esra, can you hear me?
And also oval dentate shapes, medium dominance, curved incisal edge, standard 3D dental positioning. This gives a delicate personality also to the patient.
Dear professor,
superior square dental shapes, weak dominance, horizontal incisal edge, 3D rectilinear or standard dental positioning on the arch also gives calm or stable personality to the shape. It means that we shouldn't just concentrate on the tooth only. We also consider the face and our patient's personality during creating a new smile design.
Professor, can you hear me?
Dental analyzers. In dental analyzers.
Yes, sir. Professor.
Hello.
Yeah.
Tamam. Şimdi biraz daha açıyorum. Tamam, teşekkür ederim. I'm sorry, I think you can't hear my voice. Okay, and the size and the length of central incisors are really very important. The length of the maxillary incisors are between 10.5 to 12.5 millimeter, and also the ratio is important. I mean, the width of the maxillary central incisors should be 75 to 80% of its height. This is really important, and we have to consider this ratio during making new laminate restorations, composite laminate restorations. The length of the lateral incisors is 1 to 1.5 millimeter shorter than canines, general central incisors, And also the length of the central incisors is nearly the same with the length of the canines when we compare tooth-to-tooth portion in the smile design. Generally, golden ratio is commonly used method to determine also the tooth-to-tooth proportion. Yes, this is a good ratio, commonly used ratio, but it needs a detailed calculation in the clinic, and sometimes we don't have enough time for just detailed calculations. So I generally use easier one. This is a proportion from Dr. Stephen Hughes. And according to this proportion, if the central incisors mesodistal width is x millimeter, then the lateral should measure x minus 2 millimeter, and the canine should be x minus 1 millimeter. And it means that first, we have to calculate the width-length ratio of the central incisors. And according to this ratio, we may lengthen or widen the teeth. After the preparation of the length, designing the length and width of the central incisors, then we're gonna keep on with lateral incisors and canines. We have two proportions: length, central incisors similar to canine, and lateral incisors is shorter, 1 to 5 millimeter to 1 or 1.5 millimeter from central incisors. And we have also one calculation with which if the central incisor is x, lateral incisors x minus 2, and canine x minus 1. We have to use both formulas for designing the width and length of the anterior tooth by the smile design, any digital technique or manual technique. But we have to consider this feature when we are making this plan. Central incisors should be symmetrical. Then we try to make lateral incisors symmetrical, and the asymmetry in the canines can be compensated with the patients. We have to consider this characteristic is purported during making a smile design, because in each case, unfortunately, we don't have enough space for making all anterior teeth symmetric. And the gingiva also is important. The gingival height of the maxillary centers and also canines should ideally be nearly at the same level, with that of the lateral incisor being 1 to 1.5 millimeter below this line. This is especially very critical in the high smile line patient, and it should be improved, corrected with a surgical periodontal surgery before the treatment, if we really want very aesthetic results in our patients. And the materials and equipment, one must keep in mind that to get better results, we should have proper materials and equipment. This is really important. First, which equipment or materials we need during the treatment? For all anterior aesthetic restorations, composite restorations, rubber dam, composite spatula, and also we will use composite brush, explorer, preparation burrs, finishing and polishing discs, finishing strips, mattress band, composite resin, adhesive system, and magnification. And all, generally, we prefer loops for the restorative dentistry. And rubber dam. There are different types and brands in the market, in different techniques, in different colors, and in different sizes. I generally prefer Nikton rubber dam, especially heavy one, for preventing the dam from tearing, because it's a really very, I think, undesirable situation in the clinic. But also you may use medium. It can be because a good option for diastema closure. The heavy one can be folded and you have to stretch the heavy one carefully if you don't want any folded area between the diastemas. And also you can use the other alternative. 3D rubber dam also is a good alternative, especially when you use suctions in the mouth. Yes, if you use rubber dam very well, you get a very clear vision and you get a very good operative area without blood, saliva, and any fluid, and also without any soft tissue. Yes, in some cases, we couldn't use rubber dam, and retraction core should be applied in that situation in the gingival sulcus to prevent the fluid and blood contamination. You have lots of an alternative in the dental market. The retraction cores are in different sizes, but for anterior restoration, generally we prefer 2-0, and the cords are in different chains, as you see. Knitted one facilitates easy packing and stays placed better than any twisted or braided core. Ultra pack generally has such kind of cord. And the burrs, also we need burrs, diamond burrs for preparation, especially in some cases for composite veneer restorations. Yes, first burr is depth marker. It's used to limit preparation depth, and we use this burr in both direct and indirect composite veneers. Chamfer burr is preferred also for preparation and making a chamfer in gingival and also proximal area. And football and flame burrs are used for finishing in composite restorations. So we have to provide also these burrs before the preparation. And hand instruments also this is a controversial issue because in the dental market there are lots of hand instruments, and the manufacturers claim that our product is very, very good, and composite never stick to our product. Yes, in the market there are lots of alternatives, as I said before. They can be from titanium nitrate, diamond, or special steel, coated and non-stick. Yes, these composite placement instruments get really good and have dentist space, sculpt, and also contour composites with complete ease. They're generally out of lovable. This is, I think, and is very good advantage. In the clinic, you can use any of them. Really, they're good, I think. Instruments, I generally prefer Elamarte or Hufedi in my clinical practice, but unfortunately, nearly all composites can stick to all materials. So during procedures, I think also you have to clean your instruments, yes, with alcohol especially. Also, there are different instruments to facilitate the placement of the composite in dental markets, like vibrating instruments, all-in-one vibrating instrument. Therefore, composite and modeling suitable for all restorations also. And their technology optimizes the thixotropic properties of composites by changing their viscosity without altering their chemical or mechanical characteristics. This is very good advantage, I think. The instruments allows for superior adaptation of composites to cavity walls and without any air bubbles, control of layer thickness with reduced thickness, and improved sculpt ability. Yes, this sounds very good in the clinical practice. Also, Optra Sculpt Pad, also it's a contouring instrument with special foam pad attachments. Also, it's designed for the efficient non-stick forming and shaping of composite fillings. But they're good play instruments, but I think in the clinical practice, you need first just thin, flexible composite spatula and also composite brush. Also, this is a very frequently asked question: should I use a composite brush and should I use a modeling resin for wetting the composite or wetting the brush? Listen, I strictly advise you to use composite brush during making any composite restorations in both anterior and posterior. Modeling brush for composite is required to improve the adaptation of composite resin and to smooth the composite restoration surface. You get also very good surface without any bubbles. For better surface perception, try to use them dry, but in some cases, you cannot slide it if they're very dry. In that cases, they are compatible with using modeling resins, modeling liquids. But also, I want to give some advices about modeling resins to you. Yes, they are resin-based materials like adhesive systems, but these are special products for as a modeling resin. This means that they are resin-based, but they do not include solvent. This is very important. So, if you want to use a wedding resin, you have to use special products that is designed for this, like modeling liquid, like modeling resin, like wetting resin. You shouldn't use adhesive between unpolymerized composite layers because adhesive systems include solvents and you have to remove the solvents after the application. If you cannot remove it, because if the composite resin is unpolymerized, you cannot remove by air drying because it will destroy the composite surface. And in that cases, there will be some bubbles, some gas between your composite layers. So between unpolymerized composite resin, we strictly advise to use just modeling resins. And also use little amount of this material. Just wet the brush because large amounts can negatively affect the surface hardness of your composite resin. Be careful. Just wet your brush. It's enough. Yes, using a composite brush during a composite application. And then burrs. I have to check the time. Yes, I have time. Diamonds and tungsten carbide burrs are also used for finishing and polishing discs, finishing and polishing wheels, interior proximal finishing strips, and polishing paste can be used for finishing and polishing today in the treatment, in the making composite veneer restorations. And yes, burrs, diamond and tungsten carbide burrs are used for finishing for raw surface. I advise first use the red ones, I mean fine burrs, because generally in that case the surface is very raw and this extra fine burrs can lead to ditches on the surface. So on the rock surface, first use fine. Then when you smooth the surface, then use extra fine burrs. Dental finishing discs are rotary tools and some of which can be used without polishing paste. So we use them in composite restorations frequently. And finishing discs can be coarse or soft and generally are typically used in a specific sequence to achieve the final nature looking polish and luster. Generally, I use medium and coarse ones to achieve the shape, general shape and line angles. And also fine and extra fines are used for polishing the proximal surface in anterior restorations. We use polishing strips. In the past, they were a little bit thick, so we use them under the contact point. But today, there are also good products, very thin products like Epitex. Epitex strips are ultra thin because the abrasive particles are not bonded to the strip by an adhesive in that product. And thanks to this feature, Epitex allows easier access in tight contact points, helping to minimize gingival damage, and also you can use them also very slowly between the contact points, in the contact points. This is an advantage, not just under the contact points. In the classical technique for polishing, diamonds or aluminum pastes are used with bristle brush and fat disc for getting a shiny surface. But this is traditional technique. In this technique, you may use aluminum oxide paste or diamond paste. Both of them is suitable for composite. For example, for ceramic, we just use diamond. And in this technique, you have to use this paste first with bristle brush and then fat disc, and you have to keep polishing until you get very shiny, very luster surface. But today, there are easier techniques. These are diamond impregnated fills, and they're used for finishing and polishing. By this way, you provide easy polishing procedure thanks to just two polishers. The pre-polisher, generally there are two polishers in the systems. Yes, the first one is nearly medium, and by this polisher, you finish the surface, and by the high shine polisher, you can finish with a very natural high gloss result in seconds. These materials facilitates the polishing procedure very well. So I strictly advise to use them in composite restorations, especially in microhybrid composites, because to polish the microhybrid composites sometimes takes longer time, and this decreases the time needed for this equipment, decrease the time needed for polishing microhybrid composites especially. And also they're autoclavable. Yes, and composite resin, especially, yes, of course, we need composite resin for composite restorations. And nowadays, we can use traditional composites and also restorative flowable composites for the composite resin restorations. As a traditional composites, you have three choices today: microhybrid composites, nanohybrid composites, and nano-filled composites. And according to knowledge in the literature, today we can say that all of them can be used in anterior restorations in terms of their mechanical strength and also shade and also aesthetic properties. All of them are suitable. We can use all of them. Today, we're going to use a product from Ceramco. LS Composite is a light curing radio-opaque microhybrid composite with extremely low shrinkage stress. Because you have to know your composite very well, its properties, its advantages, and its limitations before the restorations. And this product is free of DMA and HEMA, also proven to have extremely low shrinkage stress, good marginal seal, large number of lively, stable colors for perfect aesthetics, and also simple handling, easy sculpt, and positionally stable. We have to know also its ingredients. It includes HMA and also silanized inorganic fillers. As you see, its polymerization shrinkage amount is very low. This is very good property in terms of marginal gap, marginal adaptation, and also marginal discoloration, secondary carriers, because if the polymerization shrinkage is high, there can be gap between the restoration and also between the restoration and tooth. And also you have to know the shades in that composite set. This composite has 12 white shades and also 2 opaque shades as a dentin substitute, 8 spatial shades. Incisal shades are designed to match the natural incisal areas with a natural opalescence and level of translucency. And also this system has white shades, but no white shades. And White shades are very white, snow white shades are for very white restorations, because today many patients want a brighter and wider smile. By today's standards, the snow white is brighter and wider than the lightest shade under Vita shade guide. This means the snow whiter is a wider shade compared to B1, the whitest shade in Vita. And restorative low-level composites, and it's a new era in composite resin. This is completely different from the classical flowable composites because their filler ratio is higher than the traditional flowable composites. So their restorative flowable composite, it means that we can use these composites in all cavities without any traditional composite. Their filler ratio is nearly between 70% to 80%. Their mechanical properties are similar to that of traditional composite because of the higher filler ratio, and their wear resistance is enough so for both or for all anterior and posterior restorations. This is a new era. This material is suitable for also all composite restorations in anterior region. You can use this material for diastema closure, for composite veneers. They have also large shade scale. Also, they have, for example, opaque shades, typical flowables, but their main problem is the polymerization shrinkage, unfortunately, because typical flowables shrink about 3%, while conventional resin shrinks 2% or less than 2%. And also the application characteristic is completely different from the traditional composite because you cannot sculpt a flowable composite, but also they have tryptophobic property, so you can easily manipulate this kind of resin. Also, this has different advantage in the application. Also, you can use such flowable composite with special techniques called injection molding. It involves injecting a low viscosity resin composite in a pressured, transparent silicone matrix made from a diagnostic wax-up, aiming to replicate an already performed mock-up and improve tooth form arrangement. It's also a simple technique. But the main advantage of this technique is you can just use one tray. And the adhesive systems, they're really important in the anterior restorations, in the non-retentive restorations like composite veneers, like diastemas, because you don't have a cavity. You just want your composite to bond to the very smooth surface. This is a very challenging process in the restorative dentistry in the clinic. And adhesive systems are really important for retention, marginal discoloration, and marginal adaptation of composite veneer restorations. Today in the dental market, we have three options: etch and rinse adhesive systems, universal adhesive systems, and self-etch adhesive systems. Their main difference is their adhesion mechanisms and the etching process, etching style. I mean that in etch and rinse systems, the adhesion mechanism depends on micromechanical adhesion, and you have to etch enamel and dentin with these adhesive systems. But in self-etch adhesives, the situation is different. Their adhesion depends on both micromechanical and chemical adhesion, and you can etch the enamel if you want to improve the adhesion to enamel, but you shouldn't etch the dentin in classical self-etch systems. The other alternative is the universal adhesives. Yes, also their adhesion mechanism depends on micromechanical and chemical adhesion, but you can use them without etching the enamel or dentin, but also it's optional. Also, you can use it with acid etch on enamel and dentin. This is the advantage of these systems. You can use universal adhesives in all adhesive modes. This is really very good advantage of these systems. And the main difference of universal and self-etch adhesives, you cannot use classical self-etch adhesives with acid etching on dentin, but you can use universal adhesives with acid etching on dentin, because acid etching of dentin with classical self-etch systems unfortunately decrease the bond strength of these adhesives to dentin. But for composite veneers, especially when we work on enamels, we have to use acid. I mean that we have to make a pre-etching in all adhesives. It means that the adhesive system that you use is not important, but on when you make a composite veneer restorations, if you work on enamel, you have to use acid before the application of self-etch or HMS adhesive. And dentin, because sometimes because of caries or any defects, we have to work on dentin, also making the composite veneer restorations. In the situation, if the dentin is a normal dentin, healthy dentin, then in that case, generally I prefer to use self-etch or universal adhesive in self-etch mode. I don't acid the dentin if the dentin is normal in that case. But if we have to work on abraded dentin or eroded dentin, in that case, I generally prefer to use universal adhesive system, but in etch and rinse mode. In that cases, I prefer to etch the dentin before the application of adhesive system. And today we're gonna use LAS Unibond. It's a light curing one component self-etch adhesive to create a permanent marginal gap-free adhesion between the tooth structure and the light curing filling fixing material. It's a product free of BCMA, TEPDMA, and also HEMA. It has a very high adhesion values, time-saving processing on patient, therefore particularly suitable for children. And also we can use this adhesive in all etching techniques, non-etch, total etch, selective etch. It means that this is a universal adhesive. It includes ethanol and water as a solvent, and it also includes ethoxylated BCMA, phosphoric acid metabolite, and initiators. As I said before, for the composite, also you have to know the properties, the ingredients of your adhesive system. This is very important in, I think, dentistry. And magnification. Magnification, I think, also is important to make a very good restoration. Magnification may facilitate the creation of stable composite resin restorations that are less likely to develop caries, cracks, or margin stays over years of service, because you pay attention to the details when you use loops or magnification. You get a clear and better vision, which leads to improved clinical performance by using loops. The working distance can be kept a comfortable constant, ensuring also upright posture throughout working life of the practitioner. Also, it's very, very beneficial for the posture of a dentist. As the magnification increases, the field that can be viewed decreases. So it's possible to obtain loops that magnify as much as today, I think, 10 times. However, in practical terms, a magnification of 2 or 2.5 would enable the dental operator to see multiple quadrant areas in focus. This is the magnification generally dentists used. But at magnifications older than 3 for 3.5, the field becomes restricted to a single quadrant, and a magnification beyond 3.5 the view becomes increasingly restricted until only a single tooth is seen. So this makes high magnification unsuitable for routine operative dentistry. So you have to choose the magnification very carefully, what you want to make with this look. This is the important point, I think, because very high magnification is helpful when you're studying on special procedures like endodontics. And yes, also we talk about treatment plans, the patient, and the materials and equipment. Now it's time to talk about the treatment stages. The treatment stages of a composite veneer restoration are shade selection, silicone index, preparing a silicone index, isolation, preparation, adhesive application, layering, finishing and polishing, and maintenance. First step is shade selection. Successful shade taking and color communication are source of great difficulties of the practitioners. First, you have to know some characteristics of the color. Color have three components: hue, chroma, and value. Hue is a type of color, for example, red, green, blue, and it is determined with the color of dentin. Chroma is the depth or saturation of the hue. And value is the brightness of the hue. Age is very important in dentistry for the color of the teeth and for shade selection, I think. In young patients, chroma is because decreased and values increase. In older patients, chroma is increased and value is decreased. Several systems have been developed to accurately aid recording color and shade, and also we are very focused on color and shade in the training programs, in the education programs, and postgraduate, and also in undergraduate. But they still have limitations regarding the degree of translucency, because the opacity and translucency of your restorations are also very, very important characteristics to get a good color match. For a perfect shade match, the opacity of composite restoration also should match the opacity of the symmetrical tooth. But unfortunately, there's no standardization there, and each composite has different opacity, even in the same category, such as enamel shade. Yes, this is a very challenging situation in the clinical practice, I think. And yes, shade matching is a very difficult step in dentistry. It should be given special attention and appropriate time before the restoration for this step. For a better shade selection, you have to answer two questions. This is just not for composite veneers, for all anterior restoration, sorry. First, which shade, what is the initial shade of tooth, and which shades of composite system should I use for catching this shade? And the principles of shade selection, tooth shade selection, is we have to use daylight, and we have to take the shade in 3 to 5 seconds. We have to use gray background, and lipstick should be removed. Tooth surfaces should be very clean, without plaque, without any accumulation, any remnants of food also. And the patient should be at the eye level of the dentist. And this means that first you have to take the patient's shade, the initial tooth shade. You can use with a scale system, or for an objective shade selection, also you can use dental spectrophotometer. During shade selection, you may be you cannot decide just one shade. In this case, you should reduce the alternatives to 2 shades. After that, you have to also decide how many shades will you use. You have to consider how many use that you have to shade. You have to consider the lost tissues. This is very important for translucency and opalescence or opalescence of the restoration. For example, there's a problem, there's a fracture in that case. You have to first, yes, try to determine the initial shade, but also you have to determine which shades, I mean enamel shades, dentin shades, or translucent shades. And you have to consider the lost tissues when you're deciding which shades you're going to use. Then you have to check the catalogs of the composite system that we will use. Which shades can be used in that system for getting A2 shade, I mean enamel shades, dentin shades, opaque shades, or some special shades. After that, use button technique. In this technique, place small composite balls onto the tooth. Dentin shade should be placed on cervical 1/3. Enamel shade should be placed close to the incisal 1/3 or in the middle. And incisal shades should be placed beyond the incisal edge to assess their translucency. You have to apply these buttons on the restorations, but the restoration on tooth, but the tooth surface shouldn't be wet. And you have to also light cure these balls after you apply them onto the tooth. Unfortunately, during the process, there can be a little bit rehydration, so also you can wash the tooth surface and the composite balls with a air water syringe in this stage. After that, you choose one shade from your 2 alternatives. And the next step is silicone index. Silicone index is an impression of the wax up intended for transferring the information into the mouth during treatment. It allows the dentist to fully focus on the application of composite layers, and also the sagittal dimensions are already perfectly defined on the cast model. Generally, the length, also the incisal edge position of the desired final result, as well as the mesial and distal angles, the incisal thickness, and also facial curvature of the restoration. And you can completely rely on the metrics to guide you in making what your patient wants, if you also argue and talk about the final result with the patient. You may use silicone index in veneer restorations for 2 reasons. One, if the patient includes, your preparation will include incisal edge, and also if there are diastema between the teeth. In that situations, generally we use silicone index also in direct composite veneer restorations. Because also we need silicone index for layering. We need a palatal wall. We use it to make a palatal wall. So for creating a silicone index, first take impression from your patient and then prepare a diagnostic cast. Second, prepare wax out for your restorations and make a silicone index with putty system from this cast model. The second alternative is if the palatal side is incisal edge position are proper, or the old restorations palatal size, incisive edge positions are proper, then you may make the silicone index directly using these old restorations. How should be the ideal silicone index? Also, I'm going to show how to make a silicone index in the second and third part of our training program in the lab, also in the live patient. But I'm going to also give some theoretical information about these techniques. It should be well adapted to the palatal sides of teeth. Bubbles should not exist on the surface. Also, it should just include incisive edge, but it shouldn't turn to facile surface. If there are excessive materials on buccal surface, you have to remove it with a scalpel. You can measure the thickness of incisive edge with a periodontal probe and smooth the index edge with a sandpaper to get a very good view, and you can take photos. Paladex is also a new instrument designed to make a palatal wall without using a silicone index. Also, it facilitates this procedure. Isolation, as I said before, is one of the biggest game changers in composite resin restorations. You can get better adhesion composite restorations without fluid or fluid contamination with a proper isolation. The best way for isolation is use a rubber dam. It prevents saliva, cervical fluids, and blood contamination. And also, all soft tissue are retracted from the operating area when you use rubber dam. And as you see, there's no soft tissue traction, no saliva, no blood, no any fluid in the operating area. Yes, this facilitates the operative procedures. Now, I couldn't work without rubber dam. Yes, I can say this. Yes, after placing the dam to the tooth onto the cervical area, you have to stabilize it, especially when you're working close to the cervical area. Because dam does through its spring action below the height of contour of a tooth, and then the floors, blinkers, and clamps can be used for retention of rubber dam. They may also help to slightly retract the gingiva, and we need this retraction when you're working very close to the cervical area, especially also in diastema closure and in direct composite veneers. We can use dental floors for stabilizing the dam on the cervical area. This is a commonly used technique. But also B4 clamp or blinkers can be used for this reason. I generally use nowadays blinkers or clamps for this aim. There are different clamps in the dental market. Anterior clamps, I mean. You may make right and left pairs by cutting the wings of clamps, because with a butterfly clamp, it's really sometimes hard to place the metal system to measure or this surface. So generally, in studying in anterior region, you need left and right pairs.
Professor, we cannot hear you. Your voice is switched off.
Tamam. Şu anda açtım.
Yeah, okay, you can hear now.
Okay. I think we have to give a break for 10 minutes because you couldn't heard, I think, my voice nearly for 2 or 3 minutes.
Yeah.
So after that break, we're gonna go on. Sorry about this technical problem.
Okay, no problem.
Okay.
10 minutes?
Thank you so much.
Okay.
10 minutes, okay? 10 minutes, I think enough.
Yeah, okay, 10 minutes is enough. Okay.
Okay, thank you so much.
See you in 10 minutes. Thank you.
Seyirciler bizi duyabiliyor mu şu anda?
Evet.
Hı hı.
There are 15 questions in question and answer box. So you can check that. So after you finish the presentation, you can ask, you can answer the questions.
Okay.
And if you wish, we can allow the people to join the meeting with their voice and, camera. So, because some of them want to ask face-to-face questions. So if we have time, we can allow them to join, right?
Okay, it's suitable for me. Also, you can
Okay.
allow for face-to-face questions.
Okay.
Correct.
Thank you.
I'm gonna stop my voice and camera for a minute if it's possible.
Not so much. 5 minutes, maybe less.
Okay, thank you so much.
Okay, thank you. Again. Yeah, you can start when you wish.
Okay, I'm ready now. Can you hear me now?
Yes, exactly. Yeah.
Okay, because now I'm using a microphone.
Oh, it's better than before. Yeah, thank you.
Thank you so much. And I don't know exactly in which slides I was on mute. Do you remember?
I think clamp. It's the beginning of clamp.
Clamp and also very sick. No clamp. Oh, before? No.
I may be wrong. I'm sorry.
No clamp.
No clamp. Yes.
Sorry.
Maybe 3 minutes ago.
Silicon
you
index
moved.
or
No, later.
maybe we can ask our audience this question.
Yes.
From which slide can I start my presentation again?
Yeah. Isolation clamps, they wrote.
Isolation and clamps. Okay.
Yeah, isolation clamp.
Like clamps, I think this one, okay? Isolation.
Yeah.
It's more.
You have to stabilize it, and isolation and clamps. Anterior clamps, I think. Isolation, anterior clamps.
Yeah, this slide is fine, I think.
Okay.
Yeah, okay.
Okay, now I can start, okay?
Yes, please.
That's all, yes. Okay, let's keep on presentation. Okay, there are different anterior clamps in dental market. And you may make right and left pairs by cutting the wings of this clamp, because when you use butterfly clamp in the anterior region, unfortunately, it's really hard to use a mattress band in that cases. So we need 2 pairs in anterior region for all composite veneers or for the other composite restorations. As I said before, if you use rubber dam isolation, you can get very clear vision with rubber dam application. And this is a different view from the isolation. And as you see, you can see the circle areas clearly, because gingival retraction can be achieved very well with rubber dam application. But unfortunately, in some circumstance, the use of rubber dam is not possible. In this case, you can use retractors. I advise you the new attractor from Ultradent Umbrella. It's a really very good tongue clip and cheap retractor, and you can use it easily, and also your patient can easily tolerate this retractor. So I strictly advise this retractor during making a restoration, composite restoration. And also you can use in cotton rolls for this AM and sections, of course. For the prevention of blood and gingival fluid contamination, also you can use retraction cords. And the adhesive system application. Yes, in the first part, you select your adhesive system that will you use, but also its application technique is very important. It's a critical issue for longer retention, better marginal adaptation, and also preventing marginal discoloration. As you see, first, the surface should be clean and dry, because any fluid, any saliva, and also any plaque can buffer the acids of your adhesive systems. But after that, unfortunately, you can't do enough demineralization. You can't make enough demineralization. Apply the acid gel onto whole surface on which you will work. For HNV's enamel etching, you should be done for 15 to 30 seconds acid etching. You should apply the acid etching for this time in etch and rinse adhesives. But when you use universal adhesive system or a self-etch adhesive system, this period should be shorter, such as 10 to 15 seconds, because these systems also includes acidic monomers. So you don't need longer times for acid etching. And apply the adhesive system to whole surface with brush or an applicator. The difference between the applicator and the brush, there are two differences. The first one is you couldn't get a tactile sensation with a brush. So in posterior, I generally prefer applicators. But also to apply the adhesive system into the small areas, into the gaps is easier with brush. So I generally use brush in anterior region instead of applicators. Follow the manufacturer's instruction when you apply the adhesive system. Apply the adhesive system, leave undisturbed for a period of time recommended by the manufacturer after end of application. This generally is 10 to 20 seconds for each adhesive system. And then dry the surface. This is very important to remove the solvents in the adhesive system. You have to remove ethanol or other solvents in the adhesive system until the adhesive film does not visibly move under filter-air pressure. This is very, very important, because if you do not remove adhesive system well, then probably it won't well polymerized. And this will cause many problems in the long-term clinical performance of your restoration. And the preparation step. The next one is preparation step. Yes, different from indirect composite veneer restorations, preparations is not obligatory, so there's not a standard preparation depth for composite veneers. It depends on the etiology. There are two options for the preparation for the composite veneers. You may use additive techniques or you may use subtractive techniques for direct composite restorations. In additive composite veneers, we just rough the surface with a fine diamond burr to remove outline hypomineralized surface, hypomineralized part of the enamel. And we use this technique for worn, abraded, or crooked teeth. But also, we can make a preparation for the direct composite veneers. Tooth preparation principles are similar to that of indirect veneers. Preparation depth generally depends on the etiology, but it's generally 0.3 to 0.5 millimeter. And in direct composite veneers, dentin exposed does not affect adhesion and does not affect the long-term clinical performance of the direct composite veneers, because the most commonly problem in the direct composite veneer is not debonding, because we use additive technique and our new adhesive systems has very good performance on both dentin enamel. But in indirect restorations, the main problem is debonding. So we need enamel for better indirect restorations, for their long-term clinical performance. The main difference between indirect and direct restorations is this adhesion mechanism. And we encounter adhesion problems with indirect composite much more compared to direct composite restorations. Yes, preparation depth depends on the etiology. and dentin exposed does not affect adhesion. And we start first from facial surface. We first start from facial preparation. And then we keep on preparation from gingival area. And this gingival preparation is needed if there will be a clear difference between initial and final restoration. It may be in the same level generally with the gingival area, or at most 0.3 millimeter below the gingival margin. And approximal preparation also is important. Generally, we don't want to open the contact points, and the preparation should be ended 0.25 millimeter in front of the contact points, and 0.2 to 0.5 millimeter chamfer preparation is preferred for approximal preparation. But sometimes we have to open the contact points when for the rehabilitation of diastema, for the diastemic closure, if there's a crowding, if there's caries on approximal surfaces, to remove the old restorations and to mask the discolored surface, and also for changing the emergency profile, we open the contact points in that cases. And incisal preparation. You can prepare incisal edge in two ways. You can use feather edge technique or butt joint technique. In the feather edge technique, incisal edge is preserved. Facial preparation reaches to the incisal edge, and facial part of incisal margin can be thinned out and be used as a palatal wall in that case. And I prefer this preparation in many cases, and when I make composite veneer restorations, especially on canines, to prevent tooth-to restoration contact during biting. Also, it has some disadvantage, but I think for composite veneer, it's a good preparation type. Feather edge design is a good for composite veneers, because by this way you prevent tooth-to restoration contact. And butt joint design, a reduction of the incisal edge is achieved in that design. The composite thickness but should be at least 1.5 to 2 millimeter to prevent the fracture of the incisal edge. As I said before, composite resin material is a little bit fragile in thick sections, so we have to preserve this thickness for the maintenance of our restorations for a longer period in the clinical conditions. Yes, also this is an example of composite veneer preparation from the clinical perspective. As you see, very small preparation, shallow preparation is enough. Another example, I use feather edge technique in this patient. And after preparation and adhesive application and layering sequence will start. First step is creating a palatal wall. Apply the composite first on the silicone index and adapt it to the palatal wall. It should be, the thickness of the palatal wall should be between 0.3 to 0.7 millimeter, and you can use enamel or incisal shades to create this palatal wall. Then a proximal wall is created using matrix system. You can use a sectional matrix bond. It's a very economical way of making a proximal wall, but there are different alternatives. Also, I'm going to show it in the practical part. You can use also special matrix systems like Unica anterior from Polidentio, from Style Italiano. And you may use also wax or like curing resin for stabilizing the band. Then Yes, this is the creation of the approximal vault. We generally prefer thin approximal vaults and short. Then apply the mean shade to the facial surface according to the contour of this surface. And if you make an incisal preparation, cut back the incisal 1/3 in this step and make mamelons in that area with the same shade. If you make just you make preparation on enamel, and if you don't want to mask any discoloration, in that case, as you are on the enamel, you have to use enamel shade, standard shade, or incisal shade. During making a veneer restorations, we generally use dentin shades, very rare, just masking a discoloration of if we reach dentin because of any defect or caries. In the other situations, I mean, when we're on enamel, we use enamel alternatives. Then apply the main shade, yes, and then apply the incisal shade, and you, by this way, finish the layering. After layering, we keep on with finishing and polishing. And for finishing and polishing, first primary anatomy, then secondary, and then tertiary anatomy. In the primary anatomy, you have to create shape of tooth, facial embrasures, 3 facial planes, and also line angles. This is the 3 facial planes of tooth, and we have to follow this inclination during creating the facial surface. This is very important. And also you have to check it from the incisal aspect if it's suitable for this tooth. And secondary anatomy, we give vertical macro texture and more visible with the V-shaped grooves during creating a secondary anatomy. In the tertiary anatomy, perimetria and various forms of surface stippling usually present in younger teeth, and secondary anatomy and tertiary anatomy makes your restoration more natural, especially in young patients, because in young patients they're very clear and they're very prudent. And this is the samples of secondary and tertiary anatomy, I mean texture of different composite composite veneers from different patients. These are the examples, yes. And some clinical cases. As you see, this is composite veneer from canine to canine. As you see, if you use classical white shades, you get very natural restorations with composite veneers. It's really hard to distinguish if this restoration or a tooth. This can be achieved by direct composite resin. So I love direct composites. And also different cases. And different cases from Ceramco. When you use classical with white shades, you can get that more natural restorations. This is a case of erosion. And we also give the other opportunities, treatment opportunities to my patient I give. And at the end of talking about the advantage and disadvantage, we decide to make composite veneer restorations to that patients, and yes, we get very good results in that patients with composites. We use microhybrid composites, LES composites, and universal adhesives in that case. And the smile, as you see, the big change in the smile. Yes, the patient was very happy at the end of the restoration. Yes, you can get very natural restorations, but nowadays, as I said before, our patients generally desire a wider smile, a brighter smile. In that cases, you can use bleach shades or snow white shades. This is an example, this is a clinical example. In that case, we use snow white shade. The initial view of teeth, yes, in this patient, there are lots of problems like caries or restorations. And yes, we remove the restorations, we make direct veneer composite restoration to that patients, and we get very good results also. Also, the smile of my patient was very changed after the treatment. From different views. In that case, also there's restorations and also discoloration. The patient wanted wider and brighter smile. I use snow white shade in that case. I a little bit changed the shape of teeth. The result was very satisfactory for the patient. You can see the also very clear change in the smile after the treatment. And also, this is an abrasion case. In general, I don't prefer composite resin restoration in the abrasion case, but this patient was undertaken, subjected to orthodontic treatment, and after the orthodontic treatment, yes, I made composite veneer restorations to that patients. After the occlusion problem was solved, I make these restorations. Also, the patient wanted wider smile, and I used snow white shade in that patient. Also, you can see the change in the smile. We made also bleaching treatment to the other teeth in that patient. Yes, smile photo is okay, but also we have to analyze our final results and our restorations from the facial aspect. Also, it's a good sample before the treatment and after the treatment. Yes, applying the proper technique is important, making good restoration is important, but I think the maintenance of these restorations for a longer time is also very, very critical during inoperative restorative dentistry. And we have to advise some factors to our patients after the composite veneers, because as I said before, also these restorations have some limitations, and the main problem, I mean, the main problem that is very important for the patient and you is fracture of the restoration. So I think you have to give some advices to your patient. First, 6 monthly professional dental cleans for all composite resin veneers, and an upgraded toothbrush and floss for home care maintenance. It means that, yes, your patients should come to controls, follow-up sessions, and also you have to improve the hygiene of your patient. First rule is that. And also second one is wearing a protective splint at night if the patient grind his teeth or clench his jaws. This is also important. avoid harsh abrasive toothpaste. Because yes, we get today our polishing system are improved and our composites are improved, so we get very luster shiny surface after the treatment. But to protect this surface, the patient should avoid use of harsh abrasive toothpaste. And habits such as opening packages with history, biting to it, chewing ice, nail biting, or pipe smoking should be avoided. And avoid staining food or drink. This is also will also prevent the surface discoloration. To prevent the surface discoloration by time, your patient should avoid staining food or drink frequently, especially. Yes, by this way, I've finished my presentation. I finished the theoretical part of the presentation. Thank you for your kind attention.
Okay, thank you very much.
I think nearly my time is over.
Yeah. Can you see the question and answer box?
Yes, I can see the question and answer
Yeah,
box, and I think there are
17
questions. Oh,
yeah.
Yes. Do you want to read the questions, or may I read and answer them?
Yeah, it's better your own.
Read and answer. Okay.
You can switch off your presentation. You can take from the.
Yes, share screen. Stop share screen. Okay, stop share screen. I stop. Can you see my slides?
No, we can see you.
Okay, thank you so much. And yes, from chats and question answer. Yes, and thank you. But
there are two boxes. One is question and answer. One is chat. So the questions is.
No, I couldn't do question answer box. After I closed my share, I couldn't see them. I could just see the chat one.
Yeah. Can you see the 3 points?
Question answer. Yes.
No,
I find it. Okay. A question from Dr. Ramla. If stump color is C4 and we want A2, so what would be the shade for opaque? Yeah. The C4 is very dark color. In that case, you may need, you can use both dentin shades, opaque shades, but I think for just the dark color, use a thin layer of opaque will be better, because C4 is really, very dark color, and we rarely encounter such colors in the clinic. In that case, I advise you to use but opaque is different from classical dentin shade. It's a special materials, and you can find opaque just from a number of brands, from a number of companies. Sorry. Yeah. Also, with lower incisors, there is also a equation. So sorry, first question. Also, this question is from Dr. Ramla. Please explain length of lower incisors with respect to upper teeth. Yes, also there is an equation between the upper and lower teeth. I think it's if we say the width of the maxillary incisor tooth is X, then the mandibular incisor, I think, is nearly X minus 3. I remember like this, but I'm not very sure. There are lots of equations in different literatures, and you can use one of them, not just golden ratio and also red ratio. There are lots of equations. You can do not memorize them. You can explore it from the internet and you can use one of them. But I think the main important is to use the simple one also if you don't use any digital system, digital smile design system. And a question from Ferit Zeylano. What do you think about the Shimbashi index for determining the correct length of it? It's like another kind of index. As I said before, the loss of index for smile design, the most common one is golden ratio, but you may use one of them. I generally prefer the one, especially for anterior teeth, the one that I told about in my presentation. And the question from Nur al-Din Ali al-Mayali. How long is it safe for retraction course stay in gums? This is also a good question. I think there's no a standard time for this purpose, but during placing a retraction cord, you have to obey some rules, like you have to first determine the right retraction call. I mean, there shouldn't, it should fit the gingival sulcus file. It shouldn't be too thick or too thin. This is very important. And also, you should have placed it into the sulcus gently. It means that you shouldn't damage the gingiva during the application. I think this is the main rule, not to damage the gingival head. But we have to do it because gingival fluid and also any bleeding from the gingiva, unfortunately, can negatively affect the bonding performance of the adhesive system and the composite, and also can discolor our composite restoration. And after this, unfortunately, we couldn't get good results, aesthetic results at the end of the restoration. Okay, the other restoration, the other, question. We were able to watch the webinar later, study further. Unfortunately, no. This is live organization, so you won't. And also, hello, I comment on the bonding on hypomineralized or hypoplasia cases and advice on trading with MIH restoration. Any shade color selection tricks? Yes, okay. The first question also, yes, hypomineralization is a problem, yes, in the adhesion. Why? Because the characteristics of these lesions, especially in the first, we have to know their histological characteristics. In the hypomineralization, sorry, it's really hard to pronunciation, this word. In this case, the surface of the enamel is very hypermineralized, but there are some porosities in the subsurface. So I think in that cases, it's better to remove this hypomineralized area. Will be better. This can be made by discs or by burrs, but just a little touch, not a classical preparation. And we can also remove this part with the acid etching, but to arrange the time is very difficult. So, for example, for such kind of restoration or in fluorosed tooth, I prefer to remove this hypomineralized area slowly, gently. Generally, its thickness should be between 20 to 100 micron. So just little touch is enough. And after that, you can use the classical etching or bonding procedure. And any shade and color tricks, it's really, this is very, very, I think, complex step and complex issue. You can have difficulties in that issue. It's really very normal because the enamel and dentin is a complex tissue, and also the composites have different shades and opacity, and it differs from one company to another company, and one product from a company to another product to the same company. So it's a very, I think, complex issue. And unfortunately, for a better shade selection, you first have to make a good shade selection in the patient, in the tooth, and then you have to know the shade and opacity of your composite very well. And you, for this aim, you have to get experience with that composite and also with the anterior restorations. And Nahed Ahmed, please, how can I attendance? Okay. Manal Al-Hussein, I'm sorry for the pronunciation, but yes, if I make any mistakes during calling your names. What is the difference between the regular composite small filling and direct composite veneer? Yes, the difference between regular small fillings generally covers such small parts of the facial surface, but if the composite restoration covers all the buccal surface, generally we call this restoration veneer restoration. And Dr. Vahdi Kılıç, the use of polishing discs during the polishing phase provides a smoother surface than polishing wheels. Impregnated with diamond particles. Since the diamond particles in this concept are harder than aluminum oxide, it can create stretches on the surface. What do you think about this issue? Also, it's a good question. Yes, for composite, but according to literature knowledge, we can say that nearly all abrasive particles like diamond or like aluminum oxide, because generally these polishing discs are impregnated with aluminum oxide, and also silicon carbide can be used for composites. And generally, diamond particles produce smoother surfaces because it's harder compared to aluminum oxide. And according to the classical knowledge, we can use both diamonds and aluminum oxide pastes and also discs, also polishers for composites. Okay. Anonymous attendee comments also on use of flowable composite as a permanent filling or combining it within non-hybrids. Is the combination better, especially in deep elevation cases? In deep elevation cases. Okay, yes, as I said before, it's a new era and it's a newly developed material. So we have really limited clinical experience and clinical also research about restorative flowable composites, but according to early results, we can say that it can be used both in anterior and posterior. I'm sorry, I missed the question. In anterior and posterior, yes, but I think and according to this research, the clinical performance of classical non-hybrid composite and flowable composite are nearly the same, but in short term. We don't have, unfortunately, long-term results because they're new materials. But generally, it is called that it can be used. So today we use this material, but unfortunately we don't have enough evidence-based results. Is the combination better in deep elevation cases? For deep elevation cases, you can use both in large cavities. To be trust in large cavities, I don't prefer, but in small cavity, because yes, it can be used, but there's no enough clinical research. So I don't prefer flowable composite in very large restorations. I'm not very large restorations, but it's my choice. According to literature or evidence-based route, unfortunately, I couldn't say you shouldn't use it. It's up to the operator's decision. And Farid Zeynalov, do you use a composite sealer such as Permaseal by Ultradent after polishing? This is also a very good question, I think, because Permaseal is a very good material, and also, yes, it can be used, but I think not in all restorations, because we generally prefer not to use any resin-based material onto the surface. But if there's a gap, or if there is a bubbles on your composite resin after finishing, in that case, you can use Permaseal. Permaseal is a very good glaze material. And we use glaze materials if there is a small gaps or small white areas near to margin or onto the surface. We don't use optical glaze materials or Permaseal for shining for lustering the surface. Generally, classical polishing is enough for that aim, for that case. And the other question, there are conflicting results in comparison of these materials in the literature, but in general, the discs are very successful. Do you think these polishings are very necessary? Okay, yes, discs are really good. Aluminum oxide is a good material, but you cannot use the discs when you're creating or polishing the grooves especially, but we can use these wheels for polishing and also for adjusting, for smoothing the grooves. So I use wheels. I love wheels, but also I love discs. I use discs then for creating approximate surfaces, for creating line angles, and also for smoothing and the facile surface. But before creating the textures, I use this. Okay. Is there any more question? I couldn't see. Yeah.
Yeah, there are some more questions.
There are some more questions. Yes. Okay. If clear silicone is unavailable, what can you use to make the clear silicone index? I don't understand this question. I mean, I don't understand what you mean with clear silicone.
I think they can put another question that describe what they mean. So you can continue, please, with another question.
Okay.
Because,
yes. Does the use of MDP containing bonds actually increase the adhesion and durability of the restorations? Yes, MDP. Yes, you're right. MDP is a very good functional monomer, and according to some research, the self-etch adhesives, including the universal and self-etch adhesives, including MDP, bond better to enamel and dental surfaces. Yes, you're right. It's a good also material, but it does not mean that adhesives that does not include MDP won't bond well. There are limited research about this, and in this research, just 1 or 3 more brands are used. So I couldn't make any comment about the other adhesive systems, other brands. Okay. An interesting explanation, long life edge doctor, valuable information. Thank you so much. Anur Elden, L.A.L. Mayali, Manal Adhesion. For how long veneers last? Yes, this is, I think, very, very good question. Yes, the main problem is the fracture, as I said before. It's up to the patient, and especially the hygiene of the patient and occlusion of the patient and the habits of the patient. But I make really direct composite veneers frequently, but if you make a good treatment plan, if you check the occlusion very well, in that case, I can give nearly 3 to 5 years for such restorations. It can last over 5 years, but yes, unfortunately there are limited research about the long-term performance of these restorations after 5 years, especially. According to my clinical experience, after 5 years, we encounter some problems in all patients nearly, but generally small problems. Not fractures in all cases. Sometimes discoloration and sometimes the dullness degrees in luster. But as I said before, we can solve these problems easily because nowadays our composites and also adhesives are very good. Just polishing, finishing, or just some repair process, small repair process, we can solve these problems. The main problem is fracture, but you can also prevent the fracture by detailed treatment plan, including occlusion and also preparation. What do you think about omnichroma composite with veneers? Yes, omnichroma is a universal on one shade composite. This is a one brand, and there are also 2 or more brands in the dental market similar to this composite omnichroma. I think it's a very good material also for composite veneers because these materials, one shade materials, is very successful when they're used instead of enamel. I mean, when they're enamel substitutes. So you can use these materials in for composite veneers. But if you're working on enamel, if you're working on dentin, you may need opaque or dentin shades because it can be more translucent compared to tooth if you use it as a dentin substitute. And Mohammed, thanks a lot for Dr. Esra. Also, thank you very much for listening to me, for your attention. And Hanan Patton, what composite brand can be used for masking for patients with fluorosis? Fluorosis case for masking saturate, if there is just opaque areas in that patient, you can use any dentin shade, I think. But if there are severe brown areas on the surface, in that case, you can use special opaquers. These special opaquers, you can find them from which companies? From GC, also from, I don't remember, I think Visco has a one opaquer. You can use these opaquers in very thin section if there are severe brown areas on the surface. It depends on the patient. It depends on the color, on the shade of the pathologies on the buccal surface. And Hatice Erçetin, dear professor, what are your clinical observations of composite veneers in long-term stability discoloration patients according to your recommendations? Yes, okay, that's also a good question. I mentioned about the stability and discoloration, and yes, yes, patients accordance to your recommendations. It's a good question, but my patients generally try to obey all the rules that I advise them. Really, they try to protect. They love their restorations a lot, so they try to protect the restorations. Also, by talking before the restoration, you can understand their desire, their habits, and if they can obey your rules or not. And if at the beginning of the restoration, if you think that they cannot obey it, then you can advise them another alternative. It will be better. And as indication is very, very important in composite veneer restoration. Yes, technique is also as I think complicated because generally you have to make six restorations together, but indication and treatment plan is really important. I'm not a dentist or a doctor. Can I see perform this non-invasive procedure with the proper training and using a non-invasive technique? Can I see perform this non-invasive procedure with proper training? I don't know. I don't understand. But he or she wants to
Yeah,
say.
they can get an appointment there from their dentist.
Yes, I agree with you. Yes, and the other, what about mock-up before start? Yes, mock-up before start. We use this mock-up in indirect restorations, but it has also additional cost. You can make a mock-up in your patient with composites, especially for take his or her desire or wants about restorations. You can also make mock-up. But I generally prefer mock-up on cast models because of its additional cost. But if you want, you can use the classical method when we use in indirect restorations, also for direct composite veneers. Hello, Professor, can we give window prep veneers in edge-to-edge incisional occlusion, or it's not aesthetic enough? Yes, window prep, you can use also window prep, but it also has some disadvantages. Yes, especially if you want to make any any change in shape, you couldn't generally use this preparation. I prefer feather edge instead of window prep veneers to eliminate tooth restoration contact as much as possible. Please, can you give us the presentation? I'm sorry, but I couldn't give my presentation. And Manal, addition, does aesthetic dentistry is profitable if you take it as your main job? Yes, I like aesthetic dentistry. And I'm not a dentist or doctor, and I can see perform. Yes. What's the average life of composite veneers? As I said before, if you obey all rules, if you make a good treatment plan, generally, I can say that, yes, it's 5 years. The patient can use it 5 years. Maybe with minor problems like surface discoloration and surface also some decrease in luster and maybe small marginal discoloration. I mean for injection molding technique. Injection molding technique, but now which one? Clear single is unable. What can you use to make clear single index for injection molding technique? You have to use clean injection, clean silicone for this technique because light curing is just possible with clear silicone. So generally clear silicone is used in injection molding technique. Can we use composite veneers with bruxism? It's also a good question. Generally, I don't prefer to make composite veneers with indicated in the bruxism, in the severe bruxism patients. If there is an indication about bruxism in that case. Thank you so much, dear Professor, for valuable presentation and answers. Thank you again also for your kind attention to my presentation. Is there any more question?
Yeah, that's finished.
Okay.
Thank you. Yeah, certainly.
I think, yes, our time also is over.
Yeah, thank you very much for your great presentation. So, the next one, sorry?
Excuse me, would you mind reminding me about...
Yes, please.
First of all, we would like to thank to Professor Esra for this information, although I didn't understand anything as dentists, which is the place which I don't want to go. No, I don't want to go to any dentist. to the good place you want to go, but you have to go, and we need you, all of you. And also, I would like to thank to our sponsor, Sarenka, as well. And Nicebridge Academy has organized these events. Nicebridge Academy has been organizing events about dentists, for the dentists, dental care professionals, internationally, events, trainings, education. You can follow us with our newsletters and social media accounts. And also, I would like to remind that you dentists have a chance to work in the UK as dentist or dental care professional, dental therapist. If you need more information, you can check our website and also email us from info@kbac.uk. Thank you very much again for listening and for this nice presentation.
And see you on Wednesday, the same time.
Yeah.
The second session of the presentation.
Yes, it will be on Wednesday
Yeah, on Wednesday.
in the lab. I will show you how to make a preparation and also layering technique, how to make a composite veneer restoration. You can watch my presentation also in the lab. Then on Friday, on live patient. Also, I'm excited about it. On live patient, yes.
Okay. Thank you very much.
Okay.
See you
Again,
on
thank
Wednesday. Yeah,